Marco help.
Sam, I don't think we can hear you.
Yeah, thank you. I was going to say we can't hear you, Sam. Thanks.
Sam can't.
No, we can't hear you.
So she can.
Sam is going to put on the screen our CME slides for everyone to receive CME credit. And we're just going to post those up there for everyone.
Would you like me to go ahead and get started?
Did you already post the slides, Sam? The CME?
No, they haven't been posted.
They have not.
Say, this activity has been approved by the LSU CME office for 1 CME credit. And if you want to receive credit, you'll need to use your professional email address and your screen name so that we can go ahead and contact you and offer you the correct credit. If you have any questions, email cme@lsuhsc.edu. Thank you.
Wonderful. Thank you. Well, welcome everyone. Welcome to our coronavirus webinar series. Today we are joined by our guest speakers, James Riopelle and Laura Bonanno. And today they're going to talk to us about anesthesia and how they have adapted to the changes and during the COVID pandemic. So welcome.
Thank you, Crystal. So I am Laura Bonanno. I'm the director of the Nurse Anesthesia Program at LSU in the School of Nursing. I've been here as a faculty member since 2003 and the director of the program since 2007. I'm a practicing CRNA. I've been a CRNA for 25 years. And during that time, I've had the pleasure of working with Dr. Riopelle for actually my entire career as a nurse anesthetist. And I'll let Dr. Riopelle introduce himself.
Hello, I'm James Riopelle. I'm the interim chair of anesthesia at LSU HSC, and I worked at Charity since 1979. Some of my very favorite work experiences, and it was a delight working with Dr. Bonanno when she was a student, a CRNA, and as director of the school. I'm looking forward to sharing this presentation with her.
Okay, so we'll go ahead and get started. And as she mentioned, we're going to be talking about anesthesia providers adapting to changing practice and roles during the COVID-19 pandemic. And of course, we're all adjusting to technology, which doesn't ever seem to work when we're trying to. And my screen is not adjusting. There we go. Okay. So some of the things that happened during the early phases, when it seems like almost we flipped a switch and things in all of our lives changed, including in the anesthesia world. And in the beginning, there was obviously a lack of patient testing. Anesthesia providers were responding to calls for airway and ventilation management. There were concerns for personal protective equipment. You heard a lot on the news about concerns regarding the availability of ventilators. And then there was a cancellation of elective surgeries and diagnostic procedures, which significantly impacted the training of anesthesia providers. We were seeing intensive care units overflowing. New units were being developed all over hospitals. The use of post-anesthesia care units, or what we sometimes call recovery rooms, were being used as overflow ICUs. There was concern nationwide about inadequate nursing staff to care for critically ill patients in intensive care units. And there was a concern for hospital beds overall. For anesthesia providers, this was a very different world. We went almost, again, overnight from working in the operating room or in diagnostic procedure rooms to assisting intensive care unit staff, even assuming care of patients in ICU settings. Again, the response for airway management requiring intubation or breathing tubes to be put in so that patients could be ventilated properly. There was concerns about ventilator and ventilator management, how to best do that to care for these patients. And there was the need to assist the ICU staff with positioning COVID-19 patients because it seemed like that when the patients were in the prone position, they were better able to be ventilated. So they called that proning, and anesthesia providers were called on to assist with that. And then there was talk about the potential need to use anesthesia ventilators possibly for COVID-19 patients. So nationwide, there was concern about how this would best be done. And so we were all adapting to how that was going to play out in our own settings. This actually is a picture of a CRNA that I used to work with who was deployed in the military to New York. So this is actually a CRNA who's now assuming the role in an intensive care unit of taking care of a patient as part of his military service. And I want Dr. Riopelle, just because he was on the front lines. I was not actually in the hospital, but he experienced this firsthand. So I'd like to have him say a few words about what they were experiencing on the front lines.
Thank you, Laura. The first question was, how big is this going to be? And the second question was, how are we going to care for the number of patients and give them proper care when we've never treated this disease before? The third question was, are any of us going to die doing this? There was information on the internet from major medical centers all over the world. We were going to websites from China translated into English, trying to figure out what drugs should be given, what fluid should be given, when to intubate, what position should be done, what cardiac problems we could expect, what neurological problems we could expect. So as some of our personnel were deploying and finding themselves overwhelmed with the surgical and medical intensive care of these patients, others of us were trying to figure out what kind of care should be given.
Okay. Let's see. Oops. So this is a picture showing actual proning of a patient or turning somebody into the prone position, again, to improve ventilation. The same picture, but you can see all of the personal protective equipment that everybody had to have on in order to go in to do this. And this was being done periodically, almost in shifts of having to go in and actually turn these patients into this position. So there was a lot of uncertainty during this time, and there still seems to be some uncertainty about the transmission of COVID-19. I mean, in anesthesia, we tend to be very close to the airway, so virus-carrying droplet particles can become aerolized into finer particles during airway procedures, including laryngoscopy, which is what we use to go in and insert a breathing tube, intubation, extubation, anytime we needed to kind of suction airway secretions or actually take a look into the lungs. There was concern about the aerolization of these particles into the air. And anesthesia providers are at increased risk of the infection because they are working in close proximity to the airway. So this caused us to need to make some changes to our practice. Rigorous PPE was needed, properly fitting N95 masks were needed, and there was also sometimes where powered air purifying respirators were being used. For our practice, several procedures that we would normally do under sedation or what we would call monitored anesthesia care, we were now seeing that we needed to secure the airway to risk the spread of those aerolized particles into the air. So there was concerns for dispersion of potentially contaminated exhaled gases from an open airway. There was concern about contaminating the workspace and the operating room. So like I mentioned, endoscopy procedures or other procedures that we would typically not put somebody all the way to sleep under general anesthesia. With the breathing tube, we were doing that for some of those cases. There was concern about obstetrical care and who could be in the room with a mother who may be delivering a baby at the time. How we treated lots of different things, especially like nausea and vomiting. Sometimes we would give a steroid to minimize nausea and vomiting, and there was concern about its effect on the immune system. And then the need for the use of negative pressure rooms for intubations and extubations, possibly, again, to limit the spread of the infection. There was a lot of stress involved, especially for anesthesia providers, because we were working outside of the traditional role. And Dr. Riopelle can certainly share his experience with that. But in addition, there was concerns for the exposure to the virus itself, for the anesthesia provider, as well as, were they going to bring this home to their family? So you're worried about exposure to self, exposing family members, and then hearing of our colleagues becoming ill and testing positive. So, I mean, just with the anesthesia providers, I know there were several who actually became positive for COVID-19 and experienced significant illness and the need to quarantine themselves, and then also to manage the symptoms that they were having. So I'll ask Dr. Riopelle to just share a little bit about what it was like and that stress was like in the actual operating room.
Well, the main thing was trying to do all the things that we had been told we should do without enough personnel and without enough personal protective equipment to do it. For example, we quickly ran out of the disposable blue gowns that we put on, and people were having to hang these on the wall, put their names on them, and come back and use them again. We would use the same mask for days on end, whereas in the past, we'd never use it for more than one patient. There were many, many efforts to try to prevent the spread of the disease to others. For example, all the IV pumps were outside the patient's rooms and they were run underneath the door. Everything was done in teams. We tried to watch each other's back and make sure that someone else didn't walk into a room without eye protection, because it was very easy to forget. And things that you would, for example, your initial level of fear would be enough to remind you in the beginning. Over time, you would find that you would tend to go back to what you normally did, and you would get ready to walk into the room and someone would have to tell you that you're missing some very important piece of protective equipment. Over.
So now, just to tell you a little bit about how we've kind of moved forward. The return of elective cases was very significant for us because we both are concerned about the training of nurse anesthesia students and anesthesia residents. So elective cases have returned. It's a little different though. There's preoperative screening of patients. There is still a concern about false negatives. PPE is still a concern, making sure that we have the proper equipment on, which may mean an N95 mask, eye protection, face shields, gloves, gown, etc. And then, common practice for us is securing the airway and inserting a breathing tube so that we can ventilate the patient. And that's probably one of a number of ways that our practice has changed. Sorry. So typically we would use what we call a laryngoscope, which is really just a handle and a metal blade that has a light on it that allows us to actually see in the airway so that we know that we are inserting the breathing tube into the proper place. So you can see here just this picture. This is kind of how close an anesthesia provider would typically be to the airway, which during this time and the risk of an infection is concerning. Just another example of actually somebody putting in an intratracheal tube. And again, you can see the close proximity. So what's a little different now with COVID-19 is we have had for several years the ability to use video laryngoscopy, where we actually have a little camera so we don't have to get that close to the airway. And that in the upper left corner is kind of a visual of what we would see on that camera screen, which lets us know that we're putting the breathing tube in the right place. So now it allows the anesthesia provider or the person putting in the breathing tube to be quite a distance away from the airway, not so up close, again, to limit the possibility of spreading the infection. So this is just a picture of two different devices that we may use. One is on the left-hand side, you see a McGrath, where it's got the little camera at at the end of that blade. And then the glide scope there, it's kind of a separate camera that sits off to the side, but both allow pretty much the same thing, the ability to not have to get as close and to actually see where that where the breathing tube is going to be placed. So you can see here again, just showing you the distance that, and you can also see the personal protective equipment that they're wearing, the face shield, the gloves, the gown, etc. So there's been some new kind of contraptions that have been developed over this time. One of these is just kind of like a metal, a plastic covering that can go over the airway with two holes in there for the arms to go through. I think there'll be a little bit of a learning curve on how to best do this since we're not used to having this in our way. But again, just learning how to keep not only ourselves safe, but also everyone else in the operating room. Again, here's just a plastic shield, and you can see that glide scope screen in the corner and where the distance that the provider can have from the airway. So I just wanted to kind of share a little bit about the impact that that the COVID-19 has had on the education of anesthesia providers. For nurse anesthesia students, we had cancellation of clinical rotations. And some of that was because of concerns from the Health Sciences Center and the School of Nursing standpoint, and others came from the hospitals. And then for a time period, there were no elective surgeries being done. So what were we going to do to continue the education of our students? All at the same time, we were needing to adapt to learning in a remote environment, which again is a learning curve for everyone. So we had to use some virtual simulation. Some of the clinical training was postponed for a time period, but we're catching up on that now. Our students, now that elective surgeries are back going, we're able to get them all back into clinical, although it was somewhat of a challenge. So we're very grateful to our clinical partners for letting us come back in. Sometimes we're sending personal protective equipment with our students so that we don't overburden the hospitals with having to use up some of that protective equipment that they have for their staff. But it was a challenge, and we're just very thankful that now everyone is back in and getting really good training that we've always offered to the students here at LSU. And Dr. Riopelle, just let him share a little bit about the changes to the residency training.
The changes in resident training have been very similar to the advantages and problems of the student anesthetists. There have been lots of opportunities for our residents to do invasive vascular access like central lines and arterial lines to try to keep the most critically ill COVID-19 patients alive. To our great disappointment, by the time a person is on a ventilator, their chances of survival are less than 50%. But we still try very hard to save them, and of course are very happy when that is possible. It's a very labor-intensive job to do that. They require their hearts would often become affected by the virus. They would become have low blood pressures and require very high doses of drugs to support the blood pressure. Their lungs were also terribly affected, and keeping enough oxygen in their bloods to keep them alive was a major problem. It was discovered early that putting people face down sometimes allowed the parts of the lung that were functioning to get more oxygen to the blood. That's why we would switch positions. Dialysis catheters for when people's renal kidneys would fail was not traditionally a job that we would do. We had to pick that up. So everybody was just working as hard as they could, trying to deal with the massive number of patients all at the same time, and less surgical cases at the same time.
As I shared earlier, elective procedures have resumed. I think we've gotten a lot better about figuring out how to best protect patients and providers. The clinical training, as we said, has resumed. Remote learning we're adapting to. The use of Zoom meetings and GoToMeetings has been helpful here. at LSU, the School of Nursing. We're primarily using Zoom for our classes, and we're thankful that we have a great IT support. Actually, I have Marco sitting here with me right now, who's over our IT department. So they're very helpful and supportive of the faculty. And then remote testing, we're doing that through Moodle, through Respondus lockdown browser to make sure that we keep the security of our test. And we're adapting to social distancing. We have been able to hold several labs. The faculty in the nursing anesthesia program kind of spread out, and we do it in groups of 6 students, and we make sure that everyone has a mask, and we do all of the screening things that we need to do when they're coming in. But we are able to do those critical skills labs and simulations that are necessary to prepare students to go into clinical training. We still have uncertainty about the future. We watch the news, and we know that there is concern that this could resurge later on in the year. So we're watching it very closely. We're making sure that our students are getting the training that they need and the adequate case numbers and skill numbers that are needed for them to be eligible to graduate and to be certified. So we're watching that very closely, but it's an unsettling time for all of us. And uncertainty is certainly the uncertainty about what's going to happen moving forward, in the fall is on the is a great concern for all of us. So at this time, I think we can move to any questions that anyone has. We're thankful that you all attended today, and I'm happy to answer any questions.
Thank you. I don't know if you all can hear me. I'm on my phone audio now, so it might sound a little different. But I want to go ahead and take questions. Y'all from the public, please just type them in the chat feature, which is in the lower right-hand part of your screen. And we do have some questions. One is, so how rare are ventilator shortages in normal times?
Go ahead, Dr. Riopelle.
In normal times, there are plenty of ventilators. We have ventilators in the operating rooms, we have ventilators in ICU, we have extra ventilators. It's just not a problem. We were at the point of considering using anesthesia machines as ventilators, which are not designed for that purpose. These patients would be on extremely high levels of positive end expiratory pressure, which is a technique to keep the lung from collapsing. And our anesthesia machines are not ordinarily set up to give such high pressures. So we're having to look for ways to adapt them should that be necessary. Fortunately, at the very peak time, we did not reach the point where we had to have patients in the operating rooms on ventilators before the decline began.
Right. What about, so did you all have any PPE shortages among your anesthesia providers?
Yes, we had very, very serious shortages of PPE to the point where we really couldn't keep ourselves anything close to the level of safety that we normally have. These gowns that we normally wear a single time only were hanging on the wall sometimes for a day or more. And there was a lack of hangers on the walls, as some of the nursing personnel would put new hooks on the wall. There were just not enough of them. So you'd have to stack one gown on top of another, putting the contaminated side next to the supposedly clean inside. What we ended up having to do is every time we came out of a patient's room, we would wipe down the plastic with a disinfectant impregnated wipe. We had no idea whether this was going to be adequate or not. If this had been the SARS outbreak of 2003, I think it was 2002, 2003, we would have had a lot of deaths among our personnel. They had a 15% mortality compared to the 2 or 3%. And we did not know going in whether the lapses that we were having were going to cost us our lives or not.
All right, that's very scary. We have a question from Dr. Douglas Swift. How was your experience with alternative oxygenation with BiPAP? As time went on, did you tend to delay putting patients on the ventilator? Did you change your code protocols on patients with a low probability of survival?
I am not an expert on the use of BiPAP, but I did see it used a lot. Initially, there were some concerns of whether this technique would be safe, whether it would shower the room with virus, whether it would prevent intubation. Some early recommendations from China were to intubate early. Our intensivists had a fairly good experience keeping people off ventilators with BiPAP, and sometimes after they've been extubated and having difficulty, putting them on BiPAP for a while. So the best people to answer that would be Dr. Jantz, Dr. Cantro, Dr. Happel from the ICU department, who were very, very active day and night at the hospital. But the use of BiPAP increased, and the comfort with it also increased over time.
Okay. How often, a viewer is asking, how often did anesthesia teams take their own temps, and how often was the team tested?
The answer on temperature is if every time you came in to the hospital, your temperature was checked. That is still going on. Temperature is certainly one sign that you are infected, but it's quite possible to be infectious for a good while and not have a fever yet. So unfortunately, we are continuing to be all a danger to each other to a degree that we really don't know, which is why we try to use social distancing and personal protective equipment and a lot of hand washing.
Mm-hmm. Have you set up any mental health resources for the healthcare team? We're letting them talk amongst themselves and then they'll answer.
So, here, I mean, Dr. Riopelle can answer what's going on at the hospital, but we do have campus assistants, and, when students are having stress, and this has been stressful for the students as well, even, for them going into the hospital, we do refer them to our campus assistance program at LSU. Dr. Riopelle, if you want to address what's going on at the hospital.
The Department of Psychiatry at LSU has offered, Dr. Osofsky and his wife have offered sessions. Really, in a situation this stressful, everyone becomes a support for the people around them. And it was wonderful to watch the nurses and the doctors and the respiratory therapists always being positive, watching each other's backs, being sure that we were safe, and bringing food in or doing anything we could to show our appreciation and respect for the other members of the team. I'm sure this also helped.
Right. And along the same lines, a viewer is asking, how can we best support our anesthesiology residents and CRNAs during this time?
I think allowing them to get back into clinical training was critical. And making sure that they have the correct PPE, making sure that we provide them with training on how to properly put the equipment on and take it off, and how to protect themselves and others from the spread of the virus. I think is one of the main things. But it was difficult for us for a while because, again, hospitals were overwhelmed, and training of students or residents may not have been the foremost in their mind, but it is critical to the students who are in school, and allowing them to get back into clinical training allows them to stay on their trajectory to finishing their respective programs. So that's really one of the main ways. And again, we've sent PPE with the students if that was needed to make sure that their clinical training could continue.
Mm-hmm. So is there still a need for the PPE then for the students?
I'm sorry, could you repeat that?
Oh yeah, so is there still a need then for the PPE for the students? Are you still trying to get that?
No, we have it here at the Health Sciences Center. We have PPE for the students, and I think the PPE situation, and Dr. Riopelle can speak to that, is much improved at hospitals. I think it was just, every hospital being overwhelmed and, with patients and critically ill patients over such a short period of time, that it did, deplete the availability of PPE. But it's my understanding that that's better now at the hospitals, but again, I'll let Dr. Riopelle speak to that.
We have a very good situation on PPE. The main problem now is getting people to continue to be careful. Everyone is so tired of wearing masks, wiping doorknobs, eating 6 feet away from everyone else, that the desire to get back to normal, now that the hospital is not absolutely jammed with people and forcing everyone out of the hospital except COVID-19 patients, is causing us to have to remind each other that the disease is still out there. It's not overwhelming us, but it's not gone. And since we don't really know exactly how careful to be, most of us are trying to err on the side of caution and using the PPE, which is now available.
Okay. And this is right along with what you were saying, Dr. Riopelle. A viewer is asking, what is your biggest worry as a healthcare provider about the reopening phases?
I guess the biggest worry is that we'll be back where we were. I don't know of any part of the world which has gone back to its absolute peak. Everyone worries about the economic damage which is going on. I think we're all wondering whether the riots and the demonstrations around the country and people are not able to really do social distancing, and that kind of demonstration will also set off recurrences of disease. We're just going to have to find out. We can go back to the same mode that we were in, but the economic damage, of course, will just be compounded if that happens. So I think all of us in the healthcare field are hoping that the public will continue to be careful.
Mm-hmm. And for both of you, if you all have any more questions, please post them in the chat feature at the bottom right-hand of your screen. But we do have one more question. So as healthcare providers, what gives you both the most hope in treating these patients and for the state of the pandemic moving forward?
I think what gives me the most hope is just, I mean, we've seen, we've had this happen before when we've had, crises, Hurricane Katrina, and I think is probably somewhat of a parallel into everyone having to work together to get over a very critical situation. And so anesthesia providers, nurse anesthetists, anesthesiologists, residents, students, we've learned some different roles. We've learned how to adapt to intensive care unit settings, how to work better with intensive care unit nurses, intensivists, others around the hospital, everybody focused on one common goal, protecting the patients, trying to get the patients better and protecting ourselves and our families as well from this pandemic. So I think, that it made everybody come together and work better together. It lets us know that teamwork is critical. It's critical to taking care of patients and to overcoming critical events. So I think that's probably the thing that gives me the most hope. And I think we've gotten to better habits of being really careful with taking care of ourselves, washing our hands, using personal protective equipment, understanding how important that is going forward.
Mm-hmm.
Dr. Riopelle?
That was perfect.
All right, well, I think that's all the questions we have. Thank you both so much. That was very interesting. And we really appreciate your time and your efforts. And one of our viewers did write that you were truly healthcare heroes. You were truly heroes of healthcare, he wrote. So thank you so much. And we do have just to let you all know, I did post a link where you can see the recording of this webinar. It's in our chat feature. You'll be able to see the recording in about 24 hours. We'll have it up, and you'll also be able to see the recordings of all of our past webinars. And then this Thursday at 11 a.m., we will have Dr. Suzanne Strace-Bourgeois. She's an epidemiologist, and she'll be discussing reopening Louisiana. All right, I guess that's all.
Okay, bye-bye.
Thanks, everybody. Take care.
Thank you. Bye-bye.